but my name is Tammy Dangerfield. I'm one of the physical therapists at the Pain Management Center here at the University of Utah. And I treat headaches a lot. It's not the only thing I treat, but I do treat a lot of headache. So often a kind of a combination of migraine and cervicogenic headache or myofascial headache. So we're going to kind of talk about the role of physical therapy in treating chronic headaches, including migraine. We don't specifically treat the migrainous component, but there's often a lot of other stuff that goes along with it. So a couple of things a couple of important points about physical therapy and how it can be helpful for headache. There's definitely very good evidence for cardiovascular exercise decreasing pain sensitivity to many different pain conditions, including headache. So some sort of regular cardiovascular low impact exercise is one thing that they can help you with. Probably the bigger component that most people see a PT for is the alignment piece. Skeletal alignment is excuse me, a very important part of treating headache for a couple of different reasons. Alignment, I use the term alignment instead of posture because often those are different things. Having good posture often involves kind of looking like you have better alignment, but actual alignment is somewhat different than sometimes what people are taught. But when you have good alignment through any joint in the body, that's going to require good balance between the muscles on both sides of the joint. So it really requires balanced muscle length and strength. So alignment can be a way to really help you figure out if you have balanced length and strength in your muscles. Excuse me. The purpose of that and the importance of that is that when you have good length and strength around a joint, that decreases any compression of the joint that's coming from tension in the muscles, but it also decreases compression of nerves and blood vessels and other things that run through muscles. So it really affects kind of the health of the joints, the blood vessels, the nerves, and the muscles. Any of those things that may be contributing to pain will be more functional and more balanced when you're in good alignment. Another important point to kind of rein home about alignment is it's very difficult to fix just one section of your body or one section of your spine. I think we're probably all a little bit familiar with the fact that we all spend a lot of time on computers, on phones, sitting, and we have a real tendency to kind of get into this forward head alignment and posture. I'm going to say alignment, but just trying to correct one section of your body is similar to trying to fix one part of a Jenga game with hoping that you will increase stability with the whole structure. So I really do like to think of alignment and skeletal alignment as kind of a Jenga game. If you've ever played, when all of the blocks are nicely stacked on top of one another, it's pretty stable. You're very unlikely to get out. But when there's pieces all over the place and things have kind of twisted on themselves and things are uneven, even just correcting one little part of it probably isn't going to make a difference in the whole structure. So alignment really is a whole body process. The neck alignment is kind of the focus of what we're talking about today, but if you don't address things that are going on below the neck, it's often very difficult to correct that alignment or improve that alignment. So the part of alignment that we really can change, the part of any structure in the body that has the ability to change is really the muscle tissue. The muscle is what moves, it's what's dynamic, it's what learns. So we can't really just change what's going on in a joint without changing how the muscles around it are behaving. Can't really change compression on a nerve or a blood vessel without changing the muscles and how they're moving, and again, restoring that balance in length and strength. So we're going to talk a lot about how we can affect not only alignment, but pain by really addressing what's going on in the muscles. So we're going to talk about myofascial pain. This is something that I treat very commonly, but it is something that kind of gets overlooked, I think, in general in the medical community, partly because there's no physician specialty that specializes in muscle. You know, we have orthopedic doctors and we have GI doctors and we have cardiologists, but we don't really have a doctor that kind of specializes in muscle. And I think that's one of the reasons that it gets overlooked. So myofascial pain specifically is something that we really can change and address that is really commonly associated with headaches. So myo means muscle, fascia is connective tissue that runs throughout your body. It's one continuous tissue. You might think of it as a loosely knit sweater on the inside of your body, or even kind of a spider web on the inside of your body. It actually kind of looks more like a spider web. Your organs are suspended in it, your blood vessels and nerves run through it, and there's actually a lot of communication in your nervous system that actually happens in the fascia. And it's really highly intertwined with muscle. So we talk about myofascial pain usually in terms of muscle because muscle makes a whole lot more sense to most people, but there is this whole other tissue that's called fascia that is really part of the process. So even though, again, we'll kind of talk about it in terms of muscle, fascia is a tissue that we're learning more about and that plays a big role. So just a couple of points about muscle tissue that are important. Muscle is the single largest organ of the human body. Muscles are highly vascularized and innervated, lots of blood vessels and nerves in muscle. It accounts for more than 40% of your total body weight. There are many muscles in the body, 347. So even though we might think of limbs and backs in terms of muscle, there is muscle everywhere, even in places that you might not consider there to be muscle pain. And again, like we mentioned, there's no physician specialty that really specializes in it. So sometimes it gets a little bit overlooked. When we talk about muscle pain, there is a lot of conflicting verbiage out there in the literature, amongst physicians, on the internet, lots of terms that get used kind of interchangeably, or, you know, terms that might mean two different things to two different people, overlapping meanings. So some kind of common terms that have developed in the years over the literature include muscular rheumatism, myalgic spots, myalgia, fibrositis, myofasciitis. There's lots of terms, and so I want to kind of clarify what I'm talking about when I'm talking about myofascial pain. So the term that we're going to kind of focus on is a myofascial trigger point. This is the terminology that was developed by Janet Travell and David Simons in the 50s. And they really kind of did a really nice job of kind of like accumulating that information that's kind of developed over the years and defining it in a more accessible way. So what a myofascial trigger point is a hyperirritable part of the muscle. Typically, it's a very shortened part of the muscle, and it's can be very, very painful. Hyperirritable just means that it is super sensitive, so very tender to touch. There's two classifications of trigger points that we will use. Latent trigger points is one of them, which means you have that sensitive, dense area of tissue that does limit motion, it limits strength, but it may not be causing pain all of the time unless you provoke it in some way. We can also kind of delineate active trigger points, and these are the ones that really seem to be near continuous pain generators. So those are the same irritable, dense parts of the muscle, but when they've been there long enough and they're interacting with your nervous system long enough, they tend to start causing pain all of the time, even when the muscle's at rest. And then when you provoke the muscle in some way, try to use it or stretch it, then it just gets worse. So, and they also restrict movement and strength. So we will kind of just define, the way we define myofascial pain is called myofascial pain syndrome. And that just means that you have active trigger points in your muscles. So those active trigger points, like we said, limit movement, limit strength, and cause pain, and compress joints and nerves and blood vessels because you have imbalanced strength in the region of the trigger points. So the features, the way we know we're dealing with an active trigger point, actually I'll go on to the next, or I will go over that on the next slide. Just want to point out here that trigger points can fluctuate. Any sort of muscle function, the way the muscles are moving can fluctuate between being totally normal, not having any trigger point, to having latent trigger points, to having active trigger points. And it can go back and forth on that continuum. That's one of the beautiful and frustrating parts about myofascial pain, is that muscles respond to the forces that are put on them every day, and they change. So that the good news is they change, and you can always do things to get them to work better and move more comfortably. The hard part is they can always have stresses put on them that make them less functional and more painful. So you're kind of dealing with a moving target. The other really important thing to know, and I really want to bring this to light, particularly in the setting of headaches, because many people are dealing with migraine. Myofascial pain can and very often does accompany other pain problems. So the fact that somebody has active trigger points or has myofascial pain doesn't negate that there might be something else going on. This often happens in addition to, and again, doesn't always get treated as well as it could. So other pain problems include things like migraine, arthritis, radiculopathies, neuropathies, even things that you may not think about like pancreatitis and endometriosis and kind of underlying pain problems can certainly cause the muscles around them to react. We tend to protect areas that hurt. We do it without thinking about it. It's just kind of instinctive. That guarding kind of behavior whenever anything hurts can be one of the things that really contributes to muscle imbalance. So the features that will help us know we're dealing with an active trigger point include that taut band in the tissue that you can feel. There's a difference in the density of the trigger point versus the surrounding tissue. Not everybody is able to identify this very well, but someone that's worked with them enough should be able to identify that. And I would say most patients kind of have an idea where their knots are. So what happens, just to kind of give you a graphic, if my fingers are muscle fibers, normally our muscle fibers rest in a position where they overlap slightly. When you shorten a muscle, those fibers glide over one another. And when you lengthen a muscle, those fibers glide back out. So it's very important that those fibers be able to glide over themselves. When muscles get overloaded for any reason, they'll have a tendency to shorten and just get kind of stuck in that shortened position. That dense part of the tissue, that's what we would call a trigger point. So they're very tender to palpation. They can also cause referred symptoms. And that just means that you're feeling symptoms somewhere other than where the trigger point is located that resolve when you release that trigger point. So that can include pain. It can also include just tenderness. And it can also include kind of neuropathic symptoms that you may not associate with trigger points, such as numbness or sweating or kind of restricted blood flow. So there's There's other symptoms that can go along with these that we often associate with other parts of the nervous system, that autonomic nervous system. But the trigger points can certainly be something that is provoking those similar types of symptoms. The other way we really know we're dealing with a trigger point is when you stick a needle in that dense part of the muscle and fascial tissue, you get a kind of a characteristic twitch. The muscle will twitch pretty strongly. That's one of the ways we really know we're dealing with a trigger point. So I want to just show you some of, well, actually, I think is a pretty comprehensive list of myofascial trigger points that are associated with headache. There are so many that refer into the head that you might not have ever thought about, but there's quite a few of them. So the way that the pictures and the illustrations are working is that the trigger point is delineated by an X. So that would show you where that tight band is in the tissue. And then the shading, the red shading, shows where you have referred symptoms. And they've literally gone through and stuck needles and trigger points in thousands of people to come up with these patterns, and it's pretty consistent from person to person. So the more densely shaded, so the darker red is the more common regions of referral, and then the less densely shaded still happen, they're just less common. So this is a really big player, this sternocleidomastoid muscle. There's a more superficial branch and there's a deeper branch of that muscle. These tend to refer into the back of the head, around the ear, around the eye and sinuses, forehead, very typical referral patterns for trigger points in the sternocleidomastoid. This one's pretty common. I would say most people in modern society have some of these. The trigger points in the upper trapezius can refer kind of in this ram's horn distribution, we call it. So up the side of the neck, into the temple, very, very common. Can even go in the jaw. Some of the lower trapezius trigger points can also refer right up to kind of the base of the skull. These are a couple other muscles that run in the back of the neck. The suboccipitals and the splenius cervicis can refer right up to the top of the head, right in a band-like distribution around the head. Some of these other ones are kind of classic and kind of crazy when you experience them. But trigger points in this muscle in the back of the neck, the splenius cervicis, can also refer right behind the eye, kind of lower neck. And then there's another one, it's a little different muscle, very similar location, but different muscle that refers just almost kind of right above the eye. Some of these refer into the back of the head again. So there's a lot of overlap of the referral patterns. And there's a lot of muscles in the neck. You can have a couple of these, or you can have a whole bunch of these. I would say most of the patients that I treat that have headaches have a lot of these. So, and we'll definitely have Q&A session after this, so feel free to kind of think about any questions that you might have. A lot of people have questions about the referral patterns. But just to touch on treatment, treatment really does require kind of a multimodal approach. There are some real specific things that can really help release trigger points, which is very helpful. But ultimately, if you don't restore some sort of balance in the muscles and the joints, they tend to recur a lot easier. So trigger point release, although hugely important and can be very, very helpful for pain, if you don't combine it with appropriate exercises, appropriate alignment exercises, they will tend to recur a lot easier. So typically, we will do things like starting with trigger point release and really learning how to get these tissues to kind of open back up and start moving normally again. But then you want to follow it up with some gentle stretching, some range of motion exercises, and some strengthening ultimately. but we kind of have to go in that order. If you try to strengthen trigger points away, you're probably going to be disappointed. When you have that dense part of the muscle tissue, when you try to stretch it or shorten it, lengthen it or shorten it, you tend to just move all the tissue around that area, and the trigger point tends to stay pretty immobile. So even though you can gain strength in the surrounding tissues, if you don't release the trigger point first, strengthening doesn't work very well. It certainly doesn't typically address the part of the myofascial tissue that isn't moving well. So we kind of want to go in this order. We want to release trigger points. We want to then do some gentle stretching to kind of maintain a normal resting length. And then we'd want to work on exercises where you're just moving through the range, not really adding a lot of resistance. And when that's happening pretty readily and pretty easily, then we might add some resistance to that to gain strength. So I think I see a lot of people that have tried physical therapy and been pretty frustrated with it. I think sometimes they maybe skip some steps and get to kind of some strengthening exercises that aren't really addressing the movement dysfunction. When trigger points have been there for a long time, especially, you really have to get pretty specific with them to get them to release and start moving normally. So I just want to talk a little bit about trigger point release. This is kind of the first step in retraining these muscles. And there are a couple different ways to do this. Pressure releases are something that you can do for yourself, and I'll go over the technique with that after we finish up and do some question and answer today. That involves really just applying direct pressure to that dense, tight tissue, to the trigger point. It's really kind of like a very specific stretch. So you can imagine if I have a rubber band around my fingers, I can stretch it by doing this, kind of what we would call a stretch, but I can also stretch it by doing this. And that's more of what a pressure release is really just getting pressure right on those fibers to kind of help lengthen them out. You can do massage techniques. I think these are much harder for people to do on themselves. Certainly don't discourage massage in any way. There's lots of different techniques to really physically kind of lengthen some of that tissue out. You can do trigger point injections. This is something that's typically done by a physician, and that involves, again, inserting a needle right into the trigger point, and then they will typically inject a little bit of medication, either a local anesthetic or some people do it with steroid. But the treatment is actually inserting the needle into the trigger point. We don't know why it works, but when you insert a needle into a trigger point and provoke it in that way, you'll kind of get that strong contraction, and then the muscle will release. It'll kind of relax, and we see all sorts of biochemical changes that happen after we insert a needle into the tissue. We see changes in ultrasound of the banding or the tension of those tissues, and we can see immediate improvement in range of motion and pain. So the other one that I use as a physical therapist, and not all physical therapists do this, but many do, is what's called trigger point dry needling, which again is inserting a needle into the trigger point. We use acupuncture needles. I'm not going to claim to do acupuncture because that's a very different whole set of training and location and rationale that I would never claim to do. But we use the similar needle and insert it right into the trigger point, which will cause it to release. We often will accompany that with some electrical stimulation that causes the muscle to contract over and over to kind of, again, teach the muscle a bit the difference between shortened and lengthened and that contraction and relaxation process. Okay. So that's kind of the presentation that I wanted to share with everybody. Just any questions that anyone